Thank you very much. My talk is on MEWS, enhancing patient safety through proactive nursing. I suppose most of you all might have seen this form. I think I just wanted everyone to have this in their hands so that it will make our lives easy. So this actually, my objectives of my talk would be first to describe the importance of detecting a deteriorating patient early. Then the benefits and limitations of the modified early warning score, main ways how MEWS should be implemented, and the 6 physiological parameters, systems, threshold, triggers that you will understand a little later, and how to accurately record and score parameters. And I will just take some case scenarios just to enlighten the concept. If you look at a natural course of illness, you see the y-axis and the x-axis, the severity of the disease increases when you come down on the y-axis, and there is a timeline. Usually in the initial insult, the severity, the patient's severity increases, and then you have you can see the steepness suddenly increases as when the severity increases. So you come to a stage when the disease is reversible, and after some time it becomes irreversible. So now what you need to concentrate is a phase where the disease is reversible, and this is where we should act upon and save patients. So if you look at the slippery slope of deterioration, if you look at the 2 flags, the yellow and the red flags, this is the time that we should intervene and select patients. And one of the tools that we use is the modified early warning score to detect these patients and preventing the patients going down this slippery slope. So who is a deteriorating patient? Deteriorating patient is when a patient who presents into hospital is acutely unwell or becomes acutely unwell while in the hospital. So it's you need to timely and efficiently respond to these patients, and then there are 3 critical elements of the clinical response that have been identified that will determine the patient's outcome. Number 1 is early detection. So how do you detect them early? So one of the things would be to imply those monitoring charts to these patients. Then the timeliness of response, how quickly you act upon them and how competent the responding team is. So these are the 3 factors that will make the outcome different in a critically ill patient. So this is where we now stand, the chain of prevention. We all know about the chain of survival after cardiac arrest. But of course, the most important thing is a prevention of a cardiac arrest, and that is through a chain of prevention, a collection of actions that we take. So now today we will be teaching you, so this on your red loop, you see the education is what we are going to do today. And then depending on that, so what we have learned today, we will be putting into practice, monitoring them, then recognize these patients. Once you trigger the medical team for response and save the patients from a cardiac arrest. So this is what we call chain of prevention, and we do this nowadays with what we call early warning score. There are various names given to that: National Early Warning Score, NEWS, modified early warning score or MEWS. So the latest one used in NHS UK is NEWS 2. That is slightly different from the chart that I am going to introduce to you today. So there are 6 parameters that we look at. The respiratory rate, what I would say as the most neglected parameter, clinical parameter, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness, and temperature. So I will take you through these briefly in my subsequent slides. So this is a chart in your hand. I suppose most of you all might have seen this at least, so that we in our institute, we do practice this. And I know most of the institutes do practice this, and we have actually effectively detected patients. The nurses have effectively picked up patients who are deteriorating early and saved many lives. So this is, of course, health obligatory document as well. I will show you a little later. So these are the 6 parameters, and we calculate the score, and cumulative score is taken up for decisions. Now, if you look at this graph, you can see this is the admission MEWS score and subsequent outcome. So the second line of the blue line is the percentage of deaths within 24 hours. You can see if the admission MEWS score is high, their mortality is very high. So there is a way that we could prevent these patients' death by intervening early. So even the cardiac arrest and other overall outcomes will be worse with the high MEWS score. So it's very important that we put this into practice to select patients who have a very high mortality during the first 24 hours. So this is I think this chart was initially designed by the College of Anesthesiologists, and this is what they intended to be used. All the admissions to ETUs, casualty wards, I will tell you how we have adjusted it to make it more practical, right? Then for patient care areas like adult surgical wards, all deteriorating patients, all medical wards, anticipated deterioration, other specialty wards, then intensive care units, they said all intensive care admissions should have at least 2 MEWS values 15 minutes apart. And also high dependency units, and then operating theaters, all patients who are undergoing interventions and procedures should have this thing. So but we've tried this and we found it a little difficult so sometimes we get about 70 admissions a day. It will be hectic to start MEWS chart on all the patients. So this is what we have come out with. What we have done is we have decided to come for a compromise with admission MEWS score of 3 or above will have a chart initiated. And to give my personal figures, for a casualty of 50, we get at only 5 or 6 patients. So that's not an impractical thing for a nursing point of view. And a deteriorating patient in the ward. So I will take you through some cases and show how important it is. And also this is very important that get post-procedure. So you have some patients who are going for pleural biopsies, renal biopsies, coming back to the ward, should have a chart initiated irrespective of their MEWS score. And post-surgical patients as well. So these are the 3 categories of patients in a medical unit that we would want you to start the MEWS chart. Right? So there are a few things that I would be also telling that somebody who's got end-stage, renal disease, some very poor quality of life, metastatic diseases, we will not be starting MEWS score considering the overall mortality and morbidity, and also pediatric and pregnant patients will not also have this. So these are the instances where we will not be using MEWS chart. Now, whose responsibility is it? So managing MEWS chart is a staff nurse in the ward's responsibility, supervised by the medical officers and consultants. So okay, so this is the circular which was released in 2013, and it had instructed all the institution heads to implement the MEWS chart, but unfortunately this had not been implemented in some centers, but we're really happy that it's been acted upon on most of the centers. So this actually is a H form, so it's actually a legal document, so it's in your hand, so it's called H1337. So I will take you through this very briefly, and you can see the overleaf. You can turn it around and see there are a lot of details on the other side as well. Just read for people who are not very familiar with this thing. Right. So I will take the 6 vitals and just take you through how important it is for you all to put into clinical context. So first thing will be the respiratory rate, and you have now all these will, if you just go back to the chart, there are 4 color codes: white, green, amber and red. White is 0, green is 1, amber is 2, red is 3. So that is how the scores are given, which will be given in detail here. So at a glance you can say now this is the respiratory rate. So if the respiratory rate is less than 10, less than 8 or more than 30, it's given 3 marks. And then, so likewise, you have the amber color with 2 marks, and there is no green zone in the respiratory rate. Next thing is saturation. There is a slight difference in saturation here. Now you see a yellow bar at the bottom. If the patient is on oxygen, automatically the yellow bar will score 2. Then you take the saturation, right? So there are 2 marks given for saturation. If the patient is already on oxygen, then is that clear? So the other thing is, I will tell you later, you need to you need to document the flow rate, 2 liters, 4 liters or whatever on the yellow box. 2 points will be added to the total MEWS score for these patients. So look at the pulse rate, right? Again, there is a green zone also coming with a 1 mark. And there are red zones in both if the pulse is more than 130 or less than 40, right? So there are 2 extremes of pulse values. Similarly, we only have taken systolic blood pressure. People can argue why not diastolic blood pressure, because the trials have shown the diastolic blood pressure has not been associated much with the mortality. It's the systolic blood pressure, and it will make our lives easy as well. So we go only by the systolic blood pressure, and there are again both the extremes of very high blood pressure and very low blood pressure given this thing. I think I told you about the drawbacks. There's a slight drawback here. The oxygen was given 2 marks, but we see many patients on wards with hemodynamic support, noradrenaline, dobutamine. So they are not given an additional mark, but that's a drawback in this chart. But this is a standard chart that's been used in the NHS UK that we have followed. So that's one drawback that I have noticed, but I don't think that has major implications on the final outcome. Then we go to disability. Now there's another. Now we go with we all know AVPU, alert, response to verb, response to pain, unresponsive. But here they have incorporated a C in between, where it is called ACVPU. C is confusion of recent onset. Somebody who is chronically confused will not score 3. Somebody who is coming well and suddenly becoming confused in the ward will become red and will score 3. Right? So this is very important. So final thing is the temperature that we have. Again, we have a green bar there as well. So these are the 6 parameters. In addition, we had a 2 for oxygen as well. Now this is how you plot them. So you plot them with a dot, and then you join them with a line. And it's very important, if any one of these are falling into the red category, you need to put the figure. Now, for instance, the top one has a respiratory rate above 30, and we have put it at 32 because we don't know whether then we can later on monitor if the rate is going up or not. So if the saturation is less than 90, what it is, right? Okay, likewise, so you need to, if the value falls into the red category, you need to put the value figure there just to give an impression on where we trend, whether it's an upward trend or a downward trend, right? So further information on the back of the chart, I think it's given in there's a handout with you, so I will just skip that. Now this is the most important thing. We go what we call the triggers. So we add them up and then we take them into 3 categories: low risk, medium risk, and high risk, right? In the medium risk is again divided into 2, low medium risk or medium risk, right? So now depending on this, the response is different. So if a patient has got, even if the patient has not got 4 marks, if it is one single red, it will fall into low medium risk. That's say somebody who's got a 1 red. Say somebody who is suddenly becoming confused is becoming a low medium risk, and that's something that we need to act upon. So now this is what we call the trigger threshold: low, medium, and high. Then depending on that, we go for the response, clinical response. What should we do? First thing is clinical response time. How frequently we should monitor. The low risk one will monitor 4 to 6 hourly, right? The medium, low, medium, and medium risk need to be monitored hourly. And the high risk, 7 and above, should be monitored continuously, preferably in ICU or HDU setting. So this is a frequency. Then we go for the clinical response. The urgency of the response, how quickly we should respond. the seniority, whether it's a house officer, registrar, senior registrar, or consultant who should respond. And setting, if it is 7 and above, it should be, patient will definitely be moved to a HDU or a ICU setting. So this is how this thing. So there's another thing that they have stressed. If the news score is, this is a news that is a national early warning, that's a NHS. If it is 5 or above, always suspect sepsis. Right? So there's another concept that they have gone with. Now this is another very interesting chart showing you the initial news score on a septic patient and their 30-day mortality. You can see if the news score is between 10 and 20, the mortality is very high. So again, this has shown how important this scoring to predict the outcome of patients. So we can say, so it is very important to detect this early. So I will take you through quickly within the given 4 minutes, I will just take you through few cases, right? So this is the admission chart. Everybody is following this, and on the C side, I have shown you the C side. There is a vital recording box. I think this is where all the nurses record the vitals at the time of admission, right? So where then all the 6 parameters are there, and we document admission news score. Now this is a case of a leptospirosis, suspected leptospirosis, admitted straight to the medical ward from the admissions unit, right? So this is these are the vitals, and I think you can just briefly, in the interest of time, I might not be able to let you to go through this and score it, but if you just have a brief look at that, you know the respiratory rate falls into the yellow category and the pulse rate falls into the green category, and this patient, so this is the patient's C side of the admission note filled by the nurses, and the MEWS score is 3. So what does the nurses do? So they initiate, since the score is 3, they have initiated a chart, and what I have boxed is minimum 4 to 6 hours monitoring. Inform the house. So as soon as they admit the patient, the nurses inform the house officer that there is a patient with MEWS in the ward. So the house officer immediately attends to this patient, asked to get the blood cultures, routine blood investigations, give some paracetamol for fever, start IV ceftriaxone, and monitor 4 hours. So after 4 hours, suddenly, after 4 hours, the patient being monitored and the vital parameters have come down now, right? So now the MEWS score is 2. So de-escalated to 6 hourly monitoring, because it's either 4 to 6 hourly, right? So likewise, so you can use it at the time of admission. Similarly, there's a deteriorating patient in the ward, right? Patient who was admitted with acute chest pain and a trop positive MI, but this, according to our MEWS chart, the MEWS admission was 0. But suddenly the patient is monitored and suddenly the patient deteriorates, right? Cause compressive chest pain, and you now see the vitals have changed. Saturation has dropped and you have started oxygen, respiratory rate 28, tachycardic, right? Conscious. So now, if you chart them up, you see that now the MEWS score is 6. 0 has suddenly gone to 6. So the patient falls into medium risk category, and then the patient needs immediate, inform the SRO consultant and then immediate action. Likewise, so a patient who is patient admitted with a pneumonia, and patient's admission MEWS was 3. Patient being managed in the ward, and now the patient's day 2, the patient's vitals change, and then now your MEWS score is now is 6, right? So you basically, this is the risk category medium, frequency of monitoring hourly. So this is a change in the management depending on your MEWS, right? So post-procedure patient, another one, good example, because this patient's MEWS was 0, but we said all post-procedure patients should have a MEWS chart initiated, and within few hours the patient can be de-escalated to, since the MEWS is 0, you can discontinue this monitoring, right? So this is, so in addition to these things, so if there's a patient clinical deterioration, we will always call the medical emergency team, which comprises these things, right? So this is what we call the METS form in other countries, right? So people will be familiar with this, right? So now going with our theme of the year, so we have started the audit, which I have shown at the beginning also, maintenance of patient observation chart in acute medical care setting in 5 centers, and it's ongoing now. So ladies and gentlemen, take home message, MEWS would identify clinically deteriorating patients early, Initiate and maintain MEWS chart as recommended. So we said MEWS, admission MEWS of 3 would warrant this thing. Identify the trigger threshold, low, medium or high risk. Apply the appropriate clinical response based on MEWS. Apply ABCD approach when in a deteriorating patient while being monitored, and use MEWS would reduce the ICU admissions and mortality. Thank you very much.